It's such a live bro. You and I both know it.
Oh, you wanna? Is that
Literally, like,
Hi, everyone. Oh, everyone's like, anyway.
You don't even know.
Say that again.
Name a genetic right now.
that's where I want to go work.
Hi, everybody. Thank you for being here. We're going to start right away. We're already a few minutes late, but thank you so much for being here. If you haven't grabbed food, please go ahead. For anyone on Zoom, please submit your questions using the Q&A icon. And if you're on YouTube, the comment section in the live chat is actually enabled this time, so please use that as well. Today is the sixth and last in-person teaching of the semester. And today I do feel the need to recognize the immense privilege of being able to intellectualize the plight of the Palestinians, to be able to sit here in a safe room with food and water and talk it out. I feel the need to recognize the privilege that my fear of speaking out, and probably yours as well, doesn't really compare to the fear of incessant and constant bombings. It doesn't compare to the fear of some of our speakers who have really taken on the burden of teaching us. My friend Ahmed Harzallah, who I really want to give a shout out to today. His neighborhood was just bombed last week, and his high school was also bombed. And he is trying to keep in touch with his family as best as he can. To Ru'a Rimawi, she was the speaker. She did the opening remarks for the cancer teaching. And this marks the 1 year and 7 days since her two brothers were shot in the West Bank. And to my friends in Tunisia who are Palestinians and who are doing their residency in Tunisia, one of them, his name is Hassan, and he received a phone call that let him know that 18 members of his family members were killed overnight. And so I dedicate this teaching and the series and the future teachings and any conversation that you might have over the holidays with your loved ones to any innocent lives lost. That's including Israeli hostages or Israeli victims, but also all over the diaspora. To reiterate what I said before, to open up these sessions, is that these are not meant to convince you of anything. I do recognize that this is a inherently and naturally political issue, but we are trying to focus on human suffering here. As people who have chosen this profession of healing, we are trying to focus on healing and treating humans, no matter who they are. I do encourage you to fact check everything that is being said by our speakers. Please look up sources, try to identify good sources from bad sources, identify misinformation, identify truth, and fill the room whenever you can with the unapologetic truth, especially over the holidays, as I'm sure some of these topics will be raised in your gatherings. I hope that these sessions, as they have been for me, a means of grieving at a time when grieving in public at HMS and probably elsewhere has been somehow deemed controversial. I had the privilege of building so many new connections with all of you, whether people who reached out via text message or people who have reached out after the teachings or on YouTube or on Zoom. And I would like to say read some of the heartbreaking messages that you have shared with me over the past 8 weeks. Most of these are from students, and if they're not from students, I will say that they're not. I feel like a second-class citizen. I am paranoid and feel unsafe going to class. And I want to say that these are coming from Muslim students, from Arab students, from Jewish students, from students who have people in Israel, from people all over the spectrum of identities. Even if I'm silent, I can't hide my name or my face on my residency application. I feel like I'm going crazy, like I'm the only person seeing these videos. I am gaslighting myself into thinking that the only reason we are still asking for a ceasefire at day 15, this was at day 15, is because people simply do not know what's going on. I think this one will resonate with a lot of us and a lot of my classmates. After class, I go to Vandy. Vandy is the HMS dorm. After class, I go to Vandy. I lie in my bed and I cry myself to sleep, watching Bissen, Eye on Palestine, and Mata's stories on Instagram. It breaks me to know that my friends are willing to stay silent, looking at people who could be my brothers, my sisters, my families die and say nothing. I don't want to speak up or engage in anything because it is too risky. Have you seen the resident in Ottawa who got fired? Have you seen the NYU graduate whose offer got rescinded? Have you seen the proctor at the college who got fired? Have you seen the students who got arrested at Brown? And finally, this one is from my dad. He said, "I'm proud of you," in Arabic. He said, "I'm proud of you, but please don't get shot." And when I told him I'm in good hands, don't worry about me, he said, "Zama," which means really, can I truly trust you? I know how much it is killing all of us to watch people be killed. We chose this profession to heal and treat. And if we can't heal or treat, the least we can do is talk about it. And the least we can do is speak up to protect our profession and live up to our moral duty. Hi, Ru'a. It's good to see you. This is Ru'a, by the way. She gave the opening remarks for the cancer session. Thank you, Ru'a, for being here. To my peers and my professors, I hope these sessions can equip you with the language you can use to talk about Palestine and the plight of the Palestinian healthcare worker, the patient, the colleague, the mother, the child, or the father. It is more dehumanizing to completely disengage with your students than to lean into the discomfort of actually opening the door to conversation. And though I understand the debilitating fear, the kind that muffles you into complete silence, please keep Palestine in your heart if you can't speak of it out loud. De-exceptionalize the Palestinian plight from the plight for global health equity, for your mission to be a physician for all, for your mission to heal and treat and alleviate suffering for all humans. And even if your voice can only be heard behind closed doors, it does make a difference. My friend over there, Julia, is the reason that I am here today and I'm able to do this on a weekly basis. I have my incredible group of friends, but especially Julia, and I am lucky. So please check in with your people, send them messages, tell them that you're thinking about them. And I hope that we can all keep the plight of the Palestinians, the Sudanese, the Congolese, and any marginalized communities in our hearts who are not only victims of institutionalized racism and violence, but they are victims of our institutions and deliberate inattention to equity, depending on who we're talking about. To our attendings and mentors, I want to say thank you because you have been a model of morality and ethics when those who have written the frameworks for ethics and morality are actually staying silent. So thank you for allowing me to wear my keffiyeh every day, to be able to live up as my oath that I took as a medical student before starting school. And I hope to live up to the oath when I do become a physician. Thank you. And finally, a huge thank you to Reef. Reef is a medical student at UMass Med, and she did the heavy lifting for this session in particular, and to Shadden as well. So thank you for your help. To Cheryl from Student Affairs, we only need one administrator to be in our corner, and she's the one and only. And so thank you, Cheryl. And to Merhawi, he left, but he is the IT guru who has been who let us actually be able to open these teachings to a wider audience. And finally, to our amazing panelists throughout this entire series and to our panelists today, thank you so much for taking on this huge burden. I know you must be really busy. We appreciate you, we look up to you, and we admire you dearly. So thank you. I'm going to go ahead and introduce our first speaker. Oh, yes, there are a bunch of medical schools actually. Stanford Medical School, UPenn, UChicago, St. Louis University, UMass, yes, UMass, Tufts, BU, I'm sorry if I forgot some of our collaborators, but I will give them a shout out at least in the description of the YouTube video. Thank you. Kathy Woodward is our first speaker. She has volunteered with PCRF in Gaza and the West Bank for over 10 years with pediatric cardiac surgical and cardiology teams, as well as leading educational programs to teach pediatric transport. Her roles are Vice President of the Medical Advisory Board for PCRF and an adjunct faculty in the School of Nursing at UT Health San Antonio. Thank you, Kathy.
Thank you so much. Let's get the slides up. Can you see my slides okay?
Not yet. Not yet.
Okay, let's see. Did you let me share?
Yes, you should be co-host. Yeah.
What is this one? It's not letting me bring it up. It's asking me to join the meeting. I don't know what happened. Let's see. I can get back to where I was. Huh. I'm hitting Zoom and it's telling me I have to join the meeting. I'm going to go ahead and hit.
Yeah, you can try that. And if that doesn't work, you can send me the slides and I can share them on your behalf.
Okay.
Yeah.
I'm just going to. Oh, let's see. It's still asking me to join the meeting. I don't know what happened. I'm going to try one more time. It says you've disabled the participant's screen sharing.
Oh, one moment.
Okay,
How about now?
let's try it one more time. You guys are so.
I feel like it's gonna work this time.
It's not like I've never done this before. Okay, that did it. So let me get my. Okay. Are we there?
Not quite.
Okay, well, I'll tell you what, I don't want to waste a bunch of time with slides. I only had 6 of them. They were really good though, because I don't want to eat up all this time trying to do this.
Do you want us to start with Dr. Kirkland and then you and I can figure it out? I think it's working. All right, great.
It's going to be great too. So, all right. So thank you again for the organizing committee for asking me to join you today on this webinar and allowing me to use my voice for my colleagues and in Gaza. So over the last 10 years, I've created a lot of professional relationships and friendships with many nurses, physicians, and other healthcare professionals in Gaza and the West Bank. And in fact, I am right now supposed to be in Gaza with Dr. Hussein's team, taking care of children with Dr. Kirkland after their heart surgeries. And so it's hard for me not to think about years past with those kids. The kids not so happy initially post-op, but I see their families beaming after surgery, passing around those little round chocolate candies that are individually wrapped and everybody has to take one. And they have so much relief in their faces that their child has successful surgery and we were able to repair their defect and extend their life. But that's not what is happening in Gaza today. So congenital heart disease is the leading cause of birth defects associated illness and death in children and infants. And so for a frame of reference, the CDC reports that in the United States, about 1% of all live births, the child has congenital heart disease. So that's about 10 per thousand in the United States. Vast majority of them are trivial in that they're either small atrial septal defects or small patent ductus arteriosus, or things that don't maybe require a little bit of follow-up or a cardiology visit, but not intensive care immediately after birth. 25% of that 1% is considered critical congenital heart disease. Those are things like that obstruct flow, that or single ventricle physiology where the heart just isn't formed correctly. And those children need care pretty quickly after birth, sometimes urgently after birth, and certainly they need long-term follow-up. So in the United States, the prevalence, we think about 1 million children are living in the United States with congenital heart disease right now. Kids in the United States, they get seen early, they get diagnosed early, they get appropriate and timely treatments. But that's not what's happening in Gaza today. So let's talk about congenital heart disease in Gaza. And there's not a ton of literature on this, so if anybody's looking for projects, we can maybe work together on something. But in 2015, The Lancet and Cardiology in the Young published a paper about the incidence of congenital heart disease in Gaza. And they came up with about 10 per 1,000 births, which is about the same as what the CDC reported about the United States incidence. In the article from The Lancet, which again was in 2015, they said that the incidence in North America was 6.9 per 1,000. So some discrepancy at that time, between North America and Gaza. I've been conversing with Dr. Hani Al-Falit. He's a peds cardiologist in Gaza right now. He's actually working at Al-Aqsa Hospital, which is not his normal spot. Before October 7th, he was serving at Al-Nasser European Gaza Hospital in Al-Aqsa. And if you've listened closely to the news, you've heard all three of those facilities mentioned, in particular European Gaza in the last couple of days. He said he thought the incidence was around 9 per 1,000 in Gaza. So if we try to figure out, so who's living in Gaza with congenital heart disease, we can figure out what's going on now. The World Health Organization reports that about 180 babies are being born every day in Gaza today. There's been about 59 days of war. And if you do the math, that means that over 10,000 babies have been born during this war. Let that number soak in for a second. Over 10,000 babies have been born while this war has been raging. And I wonder, what care are they receiving and how are they being diagnosed? And Dr. Falit says that in his words, he said, we lost many babies with congenital heart disease in the early days. And he said it was because they couldn't maintain them just on medical care alone. These are babies that needed cardiac cath to balloon open a valve, or cardiac surgery to get flow to the vital organs. And there is nothing going on in Gaza right now for those babies, and his term lost many babies. More recently, they have been allowed to transfer some of the more critical babies with congenital heart disease to Egypt, but not many. And there are many that are waiting. So if we extrapolate the 10,000 babies that have been born, we can imagine that about 106 have been born with congenital heart disease. And that's how many babies have been born since the war started. And the only care that kids in Gaza received before October 7th, they had congenital heart disease that needed intervention. The only way they got care was either through a visiting team like Dr. Hussein's, our team that should be there today. There's also a team from Italy that was supposed to be there the week before. Or if they are able to transfer the children out of Gaza for care. That's the only way children with severe congenital heart disease can get treated in Gaza right now. Right now and before, for that matter. So we have to talk a little bit about transferring kids out of Gaza and the whole idea of medical transfers out of Gaza, because it seems an easy thing. And if you've been in the clinical areas for very long, you realize people are getting transferred in and out all the time, and it's not a huge deal. But in Gaza, it's a huge deal. So fortunately, the World Health Organization monitors this, and they report on transfers out of Palestine for medical care every month. So you can go on their website and you can figure out what happened before and what's happening now. So in July, I just picked a month, July, and in fact, they actually quit recording it as of July 2023. So in July 2023, they reported 500 referrals for medical care for children under 18. Now, the way it works there, if you haven't been talked about this yet in any of your other programs, is that people from Gaza must request and seek approval to leave Gaza. Most people you can't just go. You have to have some reason, and medical transfers are one of the reasons that they will at least consider you being able to go out of Gaza. And in this month, they had 500 referrals, children under 18, for all kinds of medical care. Now, I wasn't able to delineate exactly how many got to leave because of congenital heart disease, because they don't keep records that way. But that's just all of them. So any reason for medical care outside of Gaza, this is how many there were. 85% of them were approved. Okay, so probably some of you going, well, 85%, that's not bad. It's not bad unless your child's the one in the 15%. Then it's bad. And this 85% approved does not include or tell you anything about how many of these were delayed, meaning that a family requested to get their child to the cardiologist in Ramallah, but they were denied. And then they were delayed and delayed again and delayed again and missed appointments. And so total children that did get their approvals were 85%. Now here's the big kicker. 49% of their parents or caregivers permits were denied. And I don't know if you have kids, but can you imagine a 2-year-old going anywhere without their parent or the person closest to them, their caregiver? It's not going to happen. And I remember when Dr. Hussein and I went on the first mission with him, we actually did our surgeries at Makasset Hospital in East Jerusalem. And we had several babies that we were taking care of who parents from Gaza had just handed them over the fence and to an ambulance, waiting ambulance, and they had come to East Jerusalem by themselves for their surgery, heart surgeries. It's unfathomable to me as a mother that I would do that I would be able to do that, but these parents were brave enough to do that. And it's not the best thing for the children. They need their parents after surgery. They need them to So that's how it works right now. And so even in the best of days, it's not an easy system. And now almost nothing is happening except for those few very critical patients getting across into Egypt. There isn't any data that I could find about how children from Gaza do once they're transferred. So I don't know, and we don't know if what kind of care they get. But in 2019, a hospital in Israel that accepts transfers from the West Bank did a study of their Israeli patients versus their Palestinian patients and how they did with congenital heart disease. And these were children from the West Bank, so it'd be, we can't necessarily say this is how it would be for the Gaza kids from Gaza, but they found that the Palestinian children who presented with congenital heart disease had higher complexity scores. They experienced delays in surgery, so for the neonates. So instead of neonates being operated on at 9 days of life, it was 15.7 days of life was the average for the Palestinian kids. And they recognized that as a big disparity. And this is really serious as well. They had a higher late mortality, possibly related to only 70% of them having any kind of a long-term follow-up with a cardiologist after their surgery. So on the best days, medical transfers are not ideal or the best kind of care for children with congenital heart disease. So I'd be really remiss if I didn't get a few words in about my wonderful nursing partners in Palestine. I'm a nurse practitioner. My nursing colleagues in Palestine do not enjoy the professional status that nurses here in the United States do, the trust that's built up, that we've built in the United States. They don't enjoy that same relationship with the people they work with. But they are creative taskmasters. They can start a pediatric IV blindfolded. I mean, I'm getting my vein viewer out and I'm lining up my stuff and I'm tearing my tape and I turn around, they've already got the IV in. They're so good at tasks and getting things done. I one time brought them some blood pressure cuffs because the previous trip they didn't have enough of them. So I brought some the next trip and they didn't fit their machine. I was so aggravated that they weren't going to fit. And I know what I would have done in the United States. I would have just thrown them aside and gone to look for the right blood pressure cuffs, but they don't have that luxury. And so they started looking for new connections and they were MacGyvering this stuff up and found ways to make them work. And they are really, really good at tasks, getting vital signs, monitoring eyes and nose, getting down on the piece of paper. Of course, there's no Epic in Gaza. We're doing paper charting and they're really good at that. However, what they don't get in their nursing training is critical thinking and assessment. And so those are the two things we primarily work on, the nurses that come on the trips with us. And when we're with them is working on critical thinking. Okay, heart rate's going down or heart rate's going up and the urine output's going down. What could that mean? What should we do? Is there some intervention that we as nurses can do that would impact that patient care? And we spend a lot of time talking about those kinds of things. We've spent a lot of time with them in the intensive care unit at European Gaza. Since they don't normally take care of critically ill children, Dr. Hussein usually brings a whole PICU team with them. And over the years, many of the nurses are the same ones every year. We're so happy to see them when we get there. And I think at least a little, they're happy to see us too. And it's been a pleasure and a privilege to work with them every year. So just to close out my part of the comments, despite the war, children are still being born in Gaza and 9 out of 1,000 have congenital heart disease that will require at least monitoring and at most some cardiac cath procedure or surgery. And I have to wonder what's happening to those children that have been born, discharged maybe early with their families who are struggling, who are homeless. No regular pediatric appointments to monitor their weight, no cardiology appointments, no surgeries, no caths. They're not available in Gaza. This is not just a disparity. This is outright inequity. And so we as healthcare professionals, it's important that we recognize it. So thank you for being here today to at least open your eyes a bit to it. And we need to work towards making sure that geography is not why a child dies of congenital heart disease. Thanks so much for your time. Best wishes to you.
Thank you so much, Kathy. Thank you for all the work you have done, and I'm sure all the work you will do. And I hope you'll get to in Gaza soon with your team. I'm sure your patients will be delighted to see you again, and that your future patients will be in good hands. Thank you so much. Our next speaker is Dr. Brandon Kirkland, and he also kindly offered to speak on behalf of Dr. Adel Hussein because he was called on a surgery last minute. So Dr. Brandon Kirkland is a native of the Florida Gulf Coast. He graduated from the University of South Alabama College of Medicine in 2010. He completed pediatrics residency at the University of Alabama at Birmingham, followed by fellowships in pediatric critical care medicine and pediatric cardiology. He is now a practicing pediatric cardiac intensivist at the University of Utah and Primary Children's Hospital. His clinical interests are focused on point-of-care ultrasound as well as ECMO and mechanical circulatory support. He has been on 2 missions to Gaza for pediatric cardiac surgery at the European Gaza Unit, and he is a member of the Palestine Children's Relief Fund Medical Advisory Board for Pediatric Critical Care. And Dr. Adel Hussein has completed his residency in general surgery at the University of Iowa Hospitals and Clinics, And he then completed his fellowship training in cardiothoracic surgery at the University of North Carolina. He also completed a congenital heart surgical training at Raleigh's Children's Hospital and Indiana University School of Medicine. He held the title of Surgeon-in-Chief for the Children's Hospital and was the William Randolph Hearts Chair in Congenital Heart Disease. Dr. Hussein has been in UF since 2008, and since that time has been to Palestine, both to the West Bank and to the Gaza Strip on a near yearly basis. During these visits, he has operated upon nearly 150 children with congenital heart disease. Thank you, Dr. Kirkland, for speaking to us today, and on behalf of Dr. Hussein as well. If you do have slides, I'm going to make you co-host.
Yes, I do. Thank you. It's my pleasure to be here. Adil sends his apologies, but he was had to go repair an Epstein's anomaly this morning, so he's going to be in the operating room for most of the day. All right, let's see if I can share my screen here. Okay. All right, it looks like you can see that. Are you getting
Yes.
this? Great. Let me just get the presentation going here. Okay, I have combined my slides with Adil's slides, and I will present both of them. And I just want to qualify this by saying that I'm very grateful for the opportunity to be speaking with you this morning. My colleagues Khulud and Dr. Hassan are probably much better positioned to speak to these issues in Palestine than I am, and so we'll look forward to hearing their thoughts during the Q&A. A lot of the information here is based on the best information that we have. However, some of these things have changed significantly over the last few days to few weeks. So apologies for any inaccurate information or things that have changed as the situation continues to change in Gaza. This is based on Dr. Hussein, one of Dr. Hussein's slides. He has done 6 trips to the West Bank and Al-Maqasid Hospital, first in 2008, and 5 trips to Gaza and the European Gaza Hospital, most recently in September 22. I have been with him on the last 2 of these trips in 2019. Then unfortunately, COVID happened and we could not go for a couple of years. And we were able to go again in September. And as Kathy mentioned, we were supposed to be in Gaza right now. We should have been performing our last operations, I think, today and tomorrow, and then turn over our patients there to the Palestinian healthcare workers in the next day or two. Unfortunately, as you are well aware, all of that has fallen apart now, and we don't know when we will be able to go back. Through Dr. Hussein's missions, they have performed 138 surgical procedures. 20% of these were neonates less than a month of age, with an average age of about 2.6 years. This is somewhat similar to what we see here in the U.S. However, our ages are going to be younger here in the U.S. Because we are able and have the privilege to operate on children who have more complex heart disease and single ventricle physiology that may not be treatable, particularly in Gaza. Every one of these missions is a large undertaking that requires lots of programmatic and team development, scheduling and logistics, obtaining supplies, getting those supplies into Israel, and then through the crossing at Erez, and then to the hospitals. We try to come up with supplies and things that we'll need for our trips, and then also have supplies that we can leave there for future missions. The average cost of these is about $20,000 to $25,000 per trip, but with treating 10 to 15 children, that's about a cost of $1,750 per child, which is very, very efficient and is very low cost compared to costs here in the United States. So it really is a testament to the work that that everyone does to be able to provide care to these children. So briefly, for those who may not be familiar, this is a map of the Gaza Strip. We have entered up here at the Erez crossing, and kind of at the top of the map here. And the hospital where we were at, the European Gaza Hospital, is in Khan Yunis, which is right here. So about 2/3 of the way down the strip. So you can it takes us most of a day to get through the crossing, to get into the hospital, and then we spend the evening when we arrive screening children. Dr. Hani that Kathy was mentioning, and one of the other pediatric cardiologists have a list of patients that they have pre-screened and are there for us to see when we arrive. We usually see around 30 something to 50 something of these children and decide who has a congenital heart defect that we can intervene upon reasonably and safely in the time that we are there, and we would be able to expect a reasonable outcome. And we also unfortunately have to select patients that may not need significant long-term complex care because that is often not available in the long term. So we then select the patients who are reasonable candidates for operation and then spend that evening planning the operations for the week. We try to do the most complex operations first so that we have those patients in our ICU for the longest and recover them while they are there, and hopefully get them stabilized before we leave, so that we are available as a resource for the local healthcare teams. And then we try to do the less complex surgeries later on in the week, so that there is an anticipated shorter recovery time for the Palestinian healthcare workers. So just some brief facts about the Gaza Strip. There's about 2.2 million residents in the Gaza Strip. This is one of the most densely inhabited pieces of land on the planet. It's about 25 miles long and 6 miles wide. The Rafah border crossing at Egypt, prior to the current war, about 400 individuals crossed per day. But that, my understanding, is now closed and there's no one crossing. I think there are some supplies, at last I heard. At Erez in the north, there's no formal way to enter or exit. It is a closed border without special permitting through the Israelis. So we have to obtain permits and go through that border crossing and undergo extensive security screening to get into Gaza, and then even more extensive security screening when we leave. The annual income in 1994 was about $2,700. That dropped in 2018 to about $1,800. The Gaza Strip sees an unemployment rate of about 44%. And if you'll remember, kind of at the height of COVID, when our employment rate was the highest it had been in many, many years, we were at about 10%. And it seemed like at that point that the world was ending. But that pales in comparison to what Gaza sees on a normal day. And all of this is significantly worse now. The poverty rate is about half of the population of the Gaza Strip. That's about twice of the poverty rate in the West Bank. And 80% of the population are on some form of assistance. There are very limited resources and industry in Gaza itself. And the Gaza Strip is mostly reliant on funds coming from outside. Water and sanitation is very difficult. About 97% of households depend upon water that's delivered by tanker trucks. 95% of the groundwater is polluted because of inadequate sewage maintenance systems, which is posing a tremendous burden now during the current war. Education is I would say, a strength of Gaza. They are very, very much in tune with being an educated population. Most of the schools function on a double shift approach, where there is one set of students that come in the morning to afternoon and one set that come in the afternoon to the evening. The average classroom size is about 40. The UN has determined that there's a need for about 600 schools and at least 18,000 more teachers. So despite all of the good work that they do, they need so much more. Healthcare, Kathy mentioned more of this than I will go into. The blockade is a significant problem with significant limitations to healthcare, and Kathy has spoken to most of that already, so I won't spend a lot of time on that. But power is also significantly limited. Some of it comes in through the grid, and they will have limited 4 to 6 hour shifts of power per day. Multiple hospitals have shut down recently, and most of the hospitals now are reliant on fuel for powering generators to supply their power. That fuel is now essentially gone, and the hospitals that are there are extraordinarily limited and are now mostly limited to providing basic medical care, first aid. They are not able to provide any significant or complex care at the current time. This is one of our missions. This was the one in 2019. You can see Kathy there in the back in the green shirt, and Minette's son, one of the other intensivists that I work with, is sitting on the ground. We were sorting all of the supplies that we brought with us on the floor of the dormitory, determining kind of what we had, what we needed. This is the dormitory of a nursing school that is on the hospital campus there at the European Gaza Hospital, and kind of our base of operations for while we were staying there. And then after we got all of this organized, we have supplies that we keep there. We kind of determined what we need and what we had, and we're able to make plans about the operations going forward. This is the operating room at the European Gaza Hospital where the cardiac operations are performed. The power is out at the moment this picture was taken, but here's the bed right here in the middle. I'm not sure if you can see my mouse or not, but the bed is here in the middle. The anesthesia machine is here at the head of the bed. Over here on the left of the screen, the kind of large cream-colored machine is an echo machine for performing transesophageal echocardiography. And over here behind the bed is the cardiopulmonary bypass machine. So that is one of the things that we also have to determine when we arrive is how is this equipment functioning? Do we have all of the equipment that we need? Khulud and Dr. Hassan can comment more on that, but there have been significant limitations in the past in having the supplies that we need. We've had to make do with different cannulas and configurations and things that we would not use normally here in the United States, but were all that we had available at the time. This is Khulud at the cardiopulmonary bypass machine, getting everything set up. Just really does some fantastic work for these kids and providing excellent care. She's one of the most experienced perfusionists that I've had the privilege of working with, and just does a fantastic job taking care of these kids. Right here, this is Dr. Hassan. Looks like putting in either an IV or an arterial line in this baby that is anesthetized right here, getting set up for the procedure. And as you can see, it looked like the power was out on that one as well. So going by phone light to put that on. This is Dr. Hussein here on the left, operating. Dave Brock, his assistant, assisting him. And then Jay Fricker is a pediatric cardiologist at the University of Florida, who comes with us and was there for performing the transesophageal echocardiography. This is, I mean, you can see here, this is the kind of incision that the operations are going on through. You're doing very complex operations. These are very complex operation under very resource-rich settings here in the United States, and even more difficult in a more resource-limited setting as we have at EGH. So really a testament to everyone who works to take care of these kids. This is the ICU that we take care of these patients in following surgery. You can see 3 beds here. Over to the right, there's 1 more bed. And then on the left, there's a small room or an alcove where there's another 2 to 3 beds that we can keep patients that have begun to recover. So we have 4 beds to take care of these kids in an area with a population of over 2 million. That is similar to what we have, the population here on the Wasatch Front in Utah, encompassing Salt Lake City and the whole urban area of the Salt Lake Valley and the extended Wasatch Front. And in our institution, we have 16 cardiac beds, so 4 times the number of beds available, not including our pediatric ICU beds. So you can see that we have there are significant limitations that the local staff are working with. But despite those limitations, they do a great job. This is me here on the left, Adil and Shannon Friesenon, one of the nurse practitioners who also came with us. We had readmitted a patient. You can see that small room to the back where we take care of the patients that are kind of more stable, and supply closet behind. This room is the extent of the ICU facility that we have there in at the European Gaza Hospital. really a kind of a small space, but an outstanding staff that really works hard. And I cannot say enough good things about the local Palestinian nurses, doctors, technicians, custodial staff. Everyone is just there working hard and working very long hours. So it really is just such a privilege to work with them. I want to give credit to the other members of the team. Minette's son on the left is one of the other intensivists. Shannon in the last picture, and then Michelle Jacobchek was one of the nurses, drinking one of the ever-present cups of coffee that the local staff were bringing us. That I really, just as I was sitting here drinking my coffee this morning, looking at this picture, just thinking kind of what they must be going through right now, that I'm sure no one has the luxuries of a cup of coffee at the moment. So this picture kind of really just hit home with me this morning, just thinking about that. And this picture, I think, deserves the most attention. This is me with 4 of the local nurses that work in Gaza and live in Gaza, and work so hard and are so fantastic at their jobs. They deserve such credit for the fantastic work that they do under such resource limited settings. And one of the difficulties is, once many of these people are trained, if they have opportunities to leave and go to other countries, many of them will. Mohammed, the nurse that's the second from the left, I know we were talking, he had a brother who had moved to Germany, and he was in the process of moving to Germany and hoping to get a job in Germany. Really was an outstanding guy, very well trained. But one of the difficulties that is experienced in Gaza is, because of all of the difficulties, people who are trained often leave because it's so dangerous for them and their family. And I mean, it's hard to say that's the wrong decision, because they face such hardship and such danger on an average day, much less on a day like today, where the whole population is just under such difficulty. So the people who are trained often then leave and go somewhere else, and so it is. It then leaves a gap there that needs to be filled by training someone else. And so that is one of the things that we are trying to do is train other people, train the local staff to provide more of this care. So I just really want to give credit, and where credit is due, to the local Palestinian nurses and doctors who work so hard and are there. We're there for a few days, and we work hard while we're there, but then we leave, and then they are doing this day in and day out. And I just cannot say enough about how outstanding they are. And then one of the things that we did at the last time that we were there is the Ministry of Health asked us to come and speak with them after the mission. That had been the first mission since the closures for COVID, and they wanted to know how the mission went, what went well, and what could have gone better. And we were telling them kind of how we were really singing the praises of the staff and how well everything had done. And then one of the assistant ministers was there, and he said, thank you. You've all said very nice things, but we want to know what went poorly. We want to know what we can do better. You've told us all the good things. Now tell us the bad things. What can we do to make this better? And I just thought that was just such an outstanding way of approaching that even in the limited settings, they want to know how they can continue to improve and how they can continue to provide excellent care for these kids. So why do we do this? I mean, really, it's the patients. These are some of our patients. This is Adil with a couple of the patients that he operated on. One of whom came in with tetralogy of Fallot, what we would call a blue tet here in the United States. He was having tet spells or hypoxic spells 7 or 8 times a day. If he had been here in the United States, he would have been operated on months ago. But his family was just dealing with this. They had no way of taking care of him. And so the fact that we were able to treat him really was just such a blessing for them. They were so unbelievably appreciative, and he did very well. And some of the other patients that we have operated on, this is one of the local nurses with one of the little girls that we operated on, just recovering, doing very well. And we're just thrilled to be able to provide care for these children. This is our group from the last mission here. There's a map of Palestine in the atrium of the nursing hospital, the nursing school, and we take a picture there. So I really just want to say thank you to everyone for their involvement with the team. So, I mean, why do we do these things? The disparities that we've discussed. We're all humans. Our humanity is one of the reasons that we do this. We are in such a privileged position here in the United States to be one of, if not the most resource-rich nation on the globe, and to be able to provide some assistance to our Palestinian neighbors is a real privilege, and really provides a lot of purpose. I mean, sometimes I feel like in the U.S. I can get lost in a lot of the administrative things that occur in our in healthcare here, but being able to help with our Palestinian neighbors is just so meaningful to me, and hopefully provides great help for them. So this is some of the, a lot of this has changed. These, as of the time that Adil put these slides together, with information, I believe from Steve at PCRF, there were significant limitations. About 3% of the average daily commodities were entering Gaza as compared to prior to the war. And remember, that's 3% compared to prior to the war. And prior to the war, things were not going great. There were significant resource limitations on the best days in Gaza. Aid deliveries to Gaza have not included fuel. The hospitals are dependent on fuel to run. Fuel at this point is pretty much exhausted. They were nearing exhaustion by the time that this information was collected, and they are exhausted now. There's about 1.5 million internally displaced people in Gaza, with about 600,000 sheltering in UN shelters, which are way over capacity for what these shelters are designed to hold. With the bombings of Gaza City, the population of Gaza City, which is about 1 million, is now displaced into the south end. That's the equivalent of, for us here in the Salt Lake Valley, of doubling the population of the Salt Lake Valley, or for you in Boston, about 1.5, doubling by 1.5 times the population of Boston, which, as I last looked, was about 650,000. So a significant resource burden for areas of the Gaza Strip that are resource limited, that are really struggling on their very best days. Gaza has been under power blackout. The sole power plant in Gaza is shut down. All power has been from backup generators. Fuel is significantly limited. Most of it is exhausted at this point. There is some limited supply of fuel coming in at the time that the Israelis and the Egyptians are allowing to come in. There, at the time of putting this together, 17 hospitals near Gaza City were remaining open. Shifa Hospital was one of them. I'm sure you all have seen that Shifa Hospital has been in the news and has been bombed, and recently, and I believe is now closing down, if not closed completely. They were working on trying to find transport out or moving premature infants in the NICU. And that hospital is essentially non-functional at the moment. Most of the functioning facilities are in the south now, in Khan Yunis and the Rafah governorates. There are about 50,000 pregnant women in Gaza currently. Kathy told you that there's been about 10,000 births since this started. Premature babies in Gaza are not getting the care they need. The incubators are without power. There are no ventilators for them. So it is truly a humanitarian crisis. Just on sewage pumping stations are not functional. There are very limited food resources. Gaza citizens are forced to consume groundwater that may be contaminated with sewage, or water from agricultural wells that contains a significant salt burden. All of this is just a significant crisis. There are some trucks coming in, bringing supplies in through the Egyptian side. There is no crossing of anything at Erez on the Israeli side. So there are in the northern Israeli side at Erez and Kerem Shalom. I think there are some at one of the southern southern crossings that limit supplies are being humans are not coming in or out. But there are some supplies that are coming through. So just a few facts about PCRF, the organization that we work with, was founded in 1991. We are a non-political and nonprofit organization. We have medical missions that go into Gaza and the West Bank to provide healthcare for children, and then we have bring children out to U.S. hospitals and hospitals around the world. Adil is on the surgical subcommittee. I am on the pediatric critical care subcommittee for the medical advisory board, and we are the boards that determine what is needed. It is done by medical staff. The division and allocation of resources, it is not done politically. So, and then as I mentioned earlier, all of these missions require significant human capital, supplies, and scenario planning and coordination efforts. Since the start of the current war, we have redirected our efforts. We are now trying to plan what we may do if and when we can get back into Gaza, and will that be sort of acute crisis healthcare? We are also making plans in the long term to work to rebuild the Palestinian health sector in Gaza. There are lots of international organizations that are interested in kind of acute management, but there is less in the way of long-term development for the healthcare sector in Gaza and Palestine in the long term. So that is one of the areas where we will be focusing our efforts. So this is credit for most of these slides goes to Adil Hussein. He is on the right, and then Steve Sosby is the director of PCRF and the founder of PCRF. He has been doing this for many years now and is a fantastic guy. And so I just want to thank him for the opportunity to work with this organization, and thank Adil for bringing me in a couple years ago. And I'm just really pleased to be able to speak with you today. Thank you so much for the opportunity. Here's some resources that you are probably all aware of, but are available on this slide if you need them. Thank you so much for the opportunity to speak with you.
Thank you so much, Dr. Kirkland, and thank you for the slides. I will make sure to share them with the audience. We're going to start our Q&A portion. I'm just going to spotlight all of our panelists and introduce the last two. Dr. Kirkland, can I ask you to unshare your screen if possible?
Oh, yes, my apologies.
No problem. Right.
Stop share. There we go. Did that work?
This is perfect. Yep. Our last two speakers are Dr. Hassan Ismail Ammar. He's a consultant anesthesiologist at Arab Care Hospital. He is the head of anesthesia at Maqasid Hospital in Jerusalem from 1996 to 2013. He's an assistant professor at Al-Quds Medical College, Pediatric Cardiac Anesthesiology Department, and he served on several missions with PCRF, Qatar Charity, Surgeons of Hope, American Charity for Pediatric Surgery, including the Gift of Life and Little Wings. And our last panelist is Khulud Nassar. She was born and raised in Jordan to a Palestinian family. She came to the U.S. in 1989 and completed her perfusionist Xavier University in Cincinnati, Ohio. And she is the chief of cardiothoracic perfusion department at Loma Linda University Health in California, where she has been since 2001. She has been part of 16 medical missions to both Gaza and Jerusalem as cardiothoracic perfusionist, and she has been privileged to host 3 young children from the West Bank who came to Loma Linda University for a no-cost surgery through PCRF. She has a deep sense of purpose and compassion and is committed to improving the health of Palestinian children, like all of our panelists probably are.
Thank you so much. Thank you so much for coming and for accepting our invitation. Khulud, Dr. Hassan, Kathy, and Dr. Brandon. So I'm going to start by telling you, Brandon, the Ministry of Health asked you, how can we help? That's not what they told me. When they saw me, instead of thanking me, they told me that you're here because it's your duty. And I think they're right. So, as many of you know, I'm a Palestinian American physician, and I'm a Harvard Medical School faculty. I work at Boston Children's Hospital. The privilege of seeing this entire wonderful team last summer when they were finishing up a mission in Gaza, and I met each and every one of you. So thank you for accepting our invitation, and thank you for the important work you do in Palestine. Just to set the scene for our students and our physicians and everyone who's watching us also online. Congenital diseases, severe congenital diseases in the world, the number one type of diseases are heart disease, followed by neural tube defects, followed by Down syndrome. So imagine how many people you see with trisomy 21. Those are 1 in 1,000. Congenital heart disease is 1 in 100. So they're very, very common. Oh, to look there. And thank you. And the work is so crucial and so essential. Dr. Hassan, I'm going to start with you. Can you share with us your experience in Gaza compared to your experience when you go internationally or even in East Jerusalem in Maqasid? Please.
Thank you for inviting me. You hear me, first of all?
Yes, loud and clear.
Thank you very much. I'm so sorry because we are doing this meeting and Zooming in a very bad situation in Palestine, talking about Gaza and West Bank. We are the same. We have war everywhere in Palestine. Unfortunately, we should have to have a mission to Gaza this month in December. Unfortunately, we had a war. A lot of people died. We have about 40,000 of injured and about 16,000 of dead people in Gaza, mostly 70%, 75% from children that we are killing to treat the children, and our goal to help children that now they are killed now. They are killing the children. My experience, we start doing cardiac surgery in 1996, but we have attempts to do cardiac surgery because at that time we don't have a cardiologist who should diagnose the kids. We started Maqasid in 1996 because Dr. Nashibi was the only cardiologist at that time. When he came from France, we start to do cardiac surgeries, cardiac catheterization, and some intervention. And then a PCRF came, and we have a big meeting with Steve, me, and Mahmoud, and we decided to start to do congenital heart disease at Maqasid. At that time, me personally, we don't have a good experience in doing. I do general pediatric anesthesia, but I don't have enough experience with doing congenital heart disease anesthesia. So the PCR helped us with bringing some colleagues, anesthetists from USA, from France, from other parts. So with the time, after 2-3 years, we start to do cases ourselves. First time.
This started at what year, Dr. Hassan? What year was that when you sat with Steve?
We started with Steve in 2000.
2000. So 23 years now.
No, in 2000 we start to do with the PCRF. We start to do to bring some teams from mainly at that time from Britain and from America. Also, we have used to contact and to work with the French people and Italian at the same time. So we start to do some congenital heart disease surgeries at that time. And at that time, we don't have, as I told you, no anesthetist, no perfusionist, good perfusionist, no nurses. So we start to build ourselves. So we start from the scratch, from the scratch. I think Kathy, one who started to come at that time and to help us and to teach the nurses. But we start to do some surgery and we improve. But the big help was from the PCRF, and actually
PCRF.
Steve was keening to build a good unit at Maqasid Hospital. So we used to have a small intensive care, and Steve helped us. We built another big intensive care, and we sent some people outside to do intensive cardiac surgery, intensive care for cardiac surgery. And me personally, I started to teach other colleagues to take care of the anesthesia. And this is in Jerusalem, in Maqasid Hospital. In Gaza, when we started in Gaza it was zero. No, even with the cardiologist there is sometimes no proper diagnosis of congenital heart disease. So the teams, they come with the cardiologist and with the anesthetist at that time, with the surgeons. So we start to do some cases, and with the help of all the teams, the Italian teams, French teams, Americans, Britain, all the teams, they come to Gaza, and we start to build the ICU, to build the surgeries and the operating room, but it's not suitable. Even there is no good light, no good cautery at that time, no good nothing. So we start to work, and finally we built something, and we did a very good thing in Gaza.
And inshallah, we'll build it again.
Inshallah.
Thank you so much. You're now in Maqasid in East Jerusalem, right? Which is one of the two big. Tell us, please.
Unfortunately, now the Maqasid Hospital, now the unit is closed because they used to have a surgeon from Germany, and the surgeon from Germany, he left to governmental hospital. He is working in Ramallah. Also, big thanks to PCRF, because they built the unit. It's a fantastic unit and very good unit in Ramallah Governmental Hospital, PMC. They have a good cath lab. They have good intensive care. They rebuilt and refurbished, renewed the operating room. They brought echocardiograms, everything. They have a cath lab, instrument, equipment, everything. We should always thank the PCR for this very, very, very big help. And
this is actually, this is how I got connected to PCRF. So a few years ago, when my youngest child became a bit older and I felt I can travel for medical missions, I of course reached to PCRF to say, I'm a physician, how can I help? And immediately Steve told me, well, there is a perfect project for you. We're opening our pediatric intensive care and pediatric cardiac intensive care, a project that PCRF invested about $7 million to build, basically to serve the Palestinian community, and especially the Palestinian children with congenital heart disease and with critical care illnesses. Perfect. Thank you so much, Dr. Hassan. And Khulud, I had the pleasure to meet you in person and speak with you over the weekend. Tell us about your experience as a top-notch American perfusionist when you went on medical missions in Gaza.
My first mission was in 2002. I was a fresh perfusionist, and it was a scary one because we went to Gaza and it was under the PLO at that time. And, you know, it's a struggle even now. When we went to 2022, it's almost the same issues, lack of supplies. And every year as we go, we say, last year we didn't have this item, we'll bring it with us this time. Then we find the other items are gone. The instrument also and the devices are not in the best shape, because they don't, like here in America, it's so easy. I don't stress about going to work. I don't stress about doing any case. I don't care what kind of case you throw at me. It's not a problem because everything is within my hand reach. And if I have any problem in the devices, even if I'm on bypass, all I have to do, call Biomed, and they will come and check the units, and they do check them every 3 months. And if I have any problem, it's getting done right away. But in Gaza, we have to check the units. I have to call before we go, and I communicate with the perfusionists there. We have actually, we have 2 young guys who help me every time, and without them, I cannot do it because they always tell me, breathe, we can do it. It's okay, because there's a lot of things missing, and I'm afraid if the electricity shut down, my machine, it's a roller pump, and I don't want to go the difference, but a roller pump, it's like you doing CPR. If you're going to do it mechanically, every 2 minutes, you need somebody else to take over to keep the blood flow, or what people
Going.
can think of is the cardiac output for that patient. So you have to use it, you use the roller pump manually, and every 2 minutes you have to change because it's tiring. So it's a scary situation. I mean, usually you go so stressed and you leave. By the time I'm done, I sleep the whole 16 hours on the flight because, every ounce of energy, it's already gone. But here is different. So every time we go, we don't know what to expect. No matter what we take with us, no matter how much communication I have with the team before I go, and I ask them that, like last time I told them I want the pump to run at least 6 hours with the heater cooler on and see how it behaves, like in a row, consecutively, and to clean the machines. And there is like the heater coolers we have all over the world. There was a huge big mycobacterium problem that the hospitals here got sued for, but nobody serviced these equipment. So I was worried. So I communicated with them, but they did an excellent job. I said, I want to see water coming out to clear that you can
drink it.
Drink it. So and they did videos for me, because they said, I don't hold back when I'm mad. Like when I see somebody,
no one in the OR holds back. I know that.
I'm worse.
But what you're saying is very important. So it's not only they're working with very limited resources. Maintenance is also an issue.
Yes.
Maintaining equipment is also an issue. But you're saying what I think everyone is echoing with you, how skilled people are despite the limited resources, the limited training, the limited exposure. They do an amazing job that if we put our teams there, if I work there with their limited resources, I don't think I can be as good as they are. Because as Kathy was saying, they're MacGyvers and they can do, they're super talented.
Even if we go alone, we can't depend on ourselves only, because without their support, it doesn't work. They are MacGyver. They fix things right away. They have excellent way, as Kathy also said, to get things done, somehow figure a way to make it work.
Yep, absolutely. What do they say? The need is the mother or the father of invention? I think the mother.
And it breaks your heart, because I went with Kathy and Dr. Adele. The first time I went with Dr. Hussein, I met him in Atlanta airport, and we went, the whole team was just me and him from America. Then that's when we met Dr. Hassan and the rest of team in Jerusalem. And we have excellent physician there. She was from Hebron. And for her, like every day and night, it doesn't matter what time we are there, she's there. And I was like, why can't she? As a Palestinian, I didn't know. I was born and raised in Jordan. I had no idea. She lived in the hospital. She was not allowed, her permit from the Israelis. She can be in the hospital, but she cannot leave. She cannot leave the hospital. She can't even go shopping if she needs anything. The hospital premises is where she
is the only permission.
The only permit she has. So she was there at 24/7, sleep in a chair in the unit, taking care of the kids that we operated on, and which she was the first assist, or Dr. Hussein, was training her, so he will let her operate also part of the operation. So she was exhausted, but she always there. And me as a Palestinian living, I never thought this is kids who come I can't imagine. I'm not a mother, but I have a lot of nieces and nephews. I can't imagine my nephew after surgery want to see his grandfather and not his mother, because some of these kids who came from Gaza
Yes.
to be operated on in Jerusalem, their mom and dad didn't have the permit. So a grandfather who's 70 years old come to accompany them. Then when that child opened, I still remember that kid. She has tetralogy of Fallot. And when she opened her eyes, she didn't even cry. She saw strangers and her grandfather, and she never cried, not once. And I bet you the minute she get in her mom's
arm,
she will cry.
she will. Yeah.
But she was scared
absolutely.
because, I mean, and that by itself will break your heart, that a child cannot have his mom to hold him after surgery.
Absolutely. And I think, Kathy, you touched on that even the 85% that get the permit, 50% of the parents don't get the permit. I think it's age, isn't it? Like the age of 55 or above. And a lot of these children, their parents are younger than 55. I want to be respectful of people's time. So if you wanted to leave because it's 2:00, please feel free to leave. Those who would like to stay, and if our wonderful panelists would like to stay, I would like to take some questions from the audience. Who would like to ask a question of the panelist?
She has her hand raised.
I'm sorry.
They're asking what can we do to support?
Yes, so one of the audience is asking, what can we do to support your team and to support the medical missions in Palestine, the humanitarian work in Gaza especially?
One of the things we have before, few years ago, like a lot of medical companies, when I go to a mission, they will freely give me product that we take, because most of the product in Gaza, it's not kept in a well conditioned. In Gaza, it's on a Mediterranean Sea, so it's a humid. So the product, sometimes we use coated product with the drugs, and it's scary for me to use these expired product. So I like to take with me like a fresh, not expired or recently expired. But now the companies, if you tell them you go into the West Bank or Gaza, they, for the past 4 years, they will not give me any product. So one of the things is, because they say we go into a hostile environment, even if it wasn't, a war zone at that time when we go in.
Yeah. So some of the limitations is from the companies that typically donate medical supplies for humanitarian reasons.
Right.
Yes,
They
if I
wouldn't
said
give
I'm
it.
going to South America, they will give it to me. And if I said I'm going to Palestine, or they will not.
So I can just say that the
Please,
medical
Kathy.
equipment, even though in previous years I always save stuff and I bring it with me as well, this is not the time to do that because nothing's getting across. And there's no way to get stuff there right now. So the biggest thing you can do is use your voice, use your hands to write letters, typing, go to contact your representatives, contact the White House, the State Department, tell them what it is we need, get this thing over so that we can get in and help those kids again. And then once we're in and we can get an idea of what we need to do first, second, third, then we could maybe be more, it'll help us more to get equipment. But right now, gathering equipment is not going to be helpful.
Yes.
Thank you. I would like to share with you a comment from one of our dear friends. He's an anesthesiologist, so a colleague of yours, Dr. Hassan. He said one key point which makes this tragic situation unique is that 10 miles away from Gaza, there are world-class medical facilities, yet none are approachable. Kids with similar conditions there are receiving care with far superior resources. All children should have access to such care. Thank you, Dr. Leibowitz, for this comment. Yeah. One of the things I learned when I was in the West Bank and Palestine is that certain diseases that we care for, I'm an intensivist, just like Dr. Kirkland, and hypoplastic left heart syndrome is a disease that we operate on. Patients survive here in the US. Those patients are considered inoperable because there's
Yes.
no follow-up and you cannot. Yes, go ahead, Dr. Hassan.
Unfortunately, if you are talking about Gaza, a lady with 10 kids, and she had a baby, a newborn with pulmonary atresia. Imagine how many operations he needs this baby, or hypoplastic left heart. This needs a lot of operations and post-operative care, and cost effectiveness is very high. So at the end, if you do one stage of surgery, but at the end the baby, they die. There is no follow-up, no adequate follow-up, no second stage surgeries. This is very, unfortunately, they die. Hardly I saw babies who had a PT shunt, they just go to Glen. After Glen, they die. Nobody is following. No further surgeries. So,
correct me if I'm wrong. I was told that when they get diagnosed in utero or after they're born, most of the diagnosis is after patients are born. They tell the family that, take them home. There's nothing that can be done because exactly of what you said. And these patients are operable here in the US and they survive for many years.
In US, I saw a lady who has tricuspid atresia and she was pregnant. Imagine.
Yep. Khulud, someone is asking about the name of the doctor. Jude Fahum here is asking, what's the doctor's name from Hebron?
It's a lady. What's her name?
Vivian Badr.
If you can.
Yes, Vivian Badr. I will write it down.
Vivian Badr, yeah.
Yeah, I'll write it down.
Now she's in England. She's in Scotland now.
Okay. Any question from the audience, or I can take one from online. Isaac Martinez, Bindian was asking, Gaza is under attack and all we know, the health situation is unsustainable. What about the influence of the current brutal occupation in the West Bank health system? So he's asking essentially about the situation in the West Bank from a healthcare system. Do you know how things are at Palestine Medical Center and the other hospitals in Nablus and Hebron?
They are good. They are good. We have a good health system in the West Bank. We do adult cardiac surgery, neurosurgeries, all difficult cases.
A lot of kids killed in Jenin and they got hurt. They always attack them in Jenin and Tul Karim. What happened to these kids who got hurt?
They transferred to the local hospitals. We have around local hospitals. Now there is new hospitals. They can go there. I'm talking about congenital heart disease, not about the injured kids. There is a good local hospitals in Nablus, in Jenin, in Tul Karim, in Qalqilia. They have good hospitals and good doctors also.
Isaac asking in general about these because of the attacks of the occupation on the people in the West Bank, because till now I think 130 people were killed.
320.
200.
Yes.
Yeah.
And I'm sure there is a lot of injuries. What happened to
since
these?
October 7th.
The injury is killing in the brain and the heart. They can't sustain. The injury is very brutal injury. It's very hard. They die immediately.
I have a question. Thank you, Dr. Hassan. And thank you, Khulud. That's important. What's Bank as well. One question, especially for Kathy and for Brandon. So Khulud and Dr. Hassan, I'll tell you what I was told. It's our duty. But Kathy and Brandon, in some ways, you're humanitarians with no skin in the game. What would you say for like you're not necessarily with family connection to the region, but you are with a human connection to the people and to the suffering? What would you tell our medical student and our faculty who have never been to Palestine and feel very badly about what's happening there and would want to volunteer once that is possible?
Yes, absolutely.
I feel that way. We're humans, and there's severe suffering, and kids, it's children. Oh my God. So I'm all in. And what I would tell you about volunteering is most agencies that are currently setting up to work in Gaza, not actually physically there, but getting ready to, will have some sort of a sign up something on their websites. There is a place on the PCR website if you're interested, and that comes to usually me or one of the chairs of the committees, and then there's an additional spot. Since we're not sending people right now, we're not pushing that effort right now. But when it's time, we will need you, and there will be a place for you. So just stay tuned. Look on the websites of agencies that you know of, PCRF, IMC, Save the Kids. All of those may have spots where they need people. They need people resources, and take a look at those spots and see if there's one that fits you and sounds like you, and get signed on.
Thank you.
I will echo what Kathy said, that it's just where I just sort of feel like where there is human suffering, there's a place for me to help.
Thank you so much.
Exactly.
Thank you to all of you. We have a question from Dr. Abdurrahman and then from Mariam.
Thank you very much. I actually missed a major part of this, but I hope to be able to go back and watch it. My question is that you're luckily some of the few people who can actually access Gaza and watch what's happening on the ground, especially from a healthcare perspective. I wonder if there has been or if there will be any effort to document your experiences in a kind of a documentary or something, because I've seen that has the most impact in terms of spreading the facts about what's happening on the ground.
Good idea.
Kathy, you may know more about that than I do as far as formal efforts, but I do know that PCRF has a photographer and a media person that is there on the ground in Gaza that supports all of the missions that go in. And they're photographing what we're doing. They're on PCRF social media, on Facebook and Instagram and others that is just showing what we're doing, and that we are there providing care for these kids. As far as in the current situation, I doubt that there's any availability. PCRF has sort of dismissed their local staff to be with their families. Not they're still employed, but they're not expecting them to work. And despite that, some of them are still out working, looking for kids who need care, who need something, and trying to do anything that they can. But PCRF has not asked their local staff to be involved formally and to just be with their families and do what they need to do to take care of themselves during the current situation. But in the long term, I don't know of a documentary or anything in the works, but there are people there who do media and documentation of what's happening.
And I would just add, since this is an academic audience, that the condition is ripe for research. And I don't mean the kind of research where I'm just observational research. The situation is ripe for that. So if you have an expert in your midst at the front of the room there, and many of us have been involved in research projects and published, and we are willing to work with you and work with our Palestinian colleagues to document all of this from an academic standpoint as well. So we should all be thinking about those kinds of things now too.
So basically you're opening excellent possible ways for people to help. So you can help by going there. You can help by being here, analyzing data, help writing up and documenting what's happening, and help with envisioning the future in that area, in Gaza and in Palestine. How can we get their healthcare system back standing on their feet? Maryam, please.
I just had a question about the children who aren't given permits to travel for care. What happens to those children in Gaza or wherever you guys are seeing them and aren't able to travel? What is available to them then?
Local care.
Local care, limited resources, whatever they have available, they will still try to do. If they are not able to get to Jerusalem or Egypt or out of the country for more specialized care, they get what they can locally. Some of them will die. Some of them will continue to survive with debilitating illness.
Mm-hmm.
Dr. Hassan, you wanted to say something as well.
Yes, most of them they die. Usually they die, the kids, especially when they die.
Severe diseases, yeah.
Yes, they die.
Yeah,
because it's cost effective. They cost very much, and the people, they are poor. They don't have even money to transport from Gaza to Jerusalem. Sometimes they don't have even 200-300 shekel, less than $100. They don't have even for transport. Sometimes we collect money for the parents to go back home or to stay in the to give them foods and etc. They don't have, even they don't have nothing to put in the clothes. They don't have clothes in Jerusalem. Sometimes they used to sleep in corridors and in the patient's room. There is no places for them. And imagine a baby who's had a surgery and complicated surgery. He should stay at least 2-3 weeks in the hospital.
Well, when Brandon was sharing the data initially, he was saying that the average household income is $1,800 a year. Like, imagine.
Imagine,
yeah. Absolutely. Did you want, Brandon? Yeah. Any other questions? Yes, please.
Firstly, I wanted to thank you for this way, right? Yeah. I wanted to thank you for your amazing presentations and for being with us today. I wonder if you guys have experienced any sort of like aggression in trying to deliver these humanitarian services, and if maybe you anticipate that after hopefully the horrors reside, or I don't know, like kind of go away. And I guess, are you scared? And how do you kind of plan to deal with it? It's scary.
Okay, if I can start and then turn it over. I have not experienced any aggression. We have had some intense security screenings. Nothing. I have never experienced anything that comes close to violence or anything. The only thing that I can think of is when we were in line at Tel Aviv the last time during the security screenings. One of the guys who, like, when they asked where you've been, what you were doing in Israel, why you were there, what you did while you were there, and we always answer honestly. We tell them exactly where we were, what we were doing, and one of our nurses just said, we were in Gaza doing heart surgery, and he just said, well, why would you go to Gaza and do heart surgery? Why would you not go to Tel Aviv or Jerusalem? And we said, well, what do you mean? Like, you have people who do this. Like, Gaza does not. And that was just sort of telling to me. And but no, as far as aggression, no. We've had some intense security screenings. They will tell you that there is no profiling or anything that goes on, but I can tell you it absolutely does. Adil is usually the one who gets the most intense screenings because his name is Adil Hussein, despite the fact that his family is from India and he has no direct connection to Palestine other than his humanitarian work there. But he just sort of rolls with it, and we've, as long as we have answered sort of truthfully and honestly and just sort of been direct, then we get a lot of questions, but I have never experienced anything like that.
Yeah, I have to I've never met a Palestinian that was not gracious and welcoming and warm and kind. And I've been doing this for 10 years. It seems like I should have met a bad one sooner or later, but not a Palestinian. I haven't. They are very warm, and I think they're forgiving people. So I'm not afraid. I'm not afraid when I'm there. Now, will I walk out in the middle of the night by myself? No, but that's because I'm a woman. And so, but in my work, never had any problems. We had a conversation with the nurses one night while we were sitting around, and the nurses were mostly men at night that worked at night, and they said, you know, we thought all Americans were fat. And I said, well, I thought all Palestinians were terrorists. So we had a good laugh over that, a big laugh over that. They're just the most fabulous, really kind, wonderful people.
That is a funny joke, but I'm glad you both laughed about it. So few last questions, and we will thank you so much for your time. So among the questions, how they can reach us, people are asking how to reach us and how to collaborate on research. I would say, please reach out to our stellar medical student. She will provide contact information that you can email her, and she can connect you with any of the speakers or with me. I am on the medical advisory board of the PCRF with this wonderful team, and I head the pediatric critical care committee. And then Jude Fahum was saying that there has been a lot of virtual consult for healthcare workers. And she thought that there isn't electricity. So is this a scam? Is this for real? What do you think about that? Kathy or Brandon or Dr. Hassan, if you want to take it. I did not think that they have access to consistent electricity. Even when we tried to talk with Dr. Ghassan and others inside Gaza, it was very challenging.
Mm-hmm.
I say, I'm not sure specifically what you're referring to, but I would say, yeah, they have almost no electricity. We have gotten communications from some of our colleagues that are there when they are in hospitals that happen to have generator capabilities working at the moment. But even if if we are able to provide kind of telemedicine consulting, the physical resources are just extraordinarily limited right now. So
yes,
there's
excellent,
very limited utility that we could make of that at the moment.
Yes, maybe they're just collecting, people's names who are interested in doing that once that is possible, perhaps. And I think the final is a comment, and it's actually a great comment to end our excellent panel discussion on. It's from Dr. Isaac Martinez Bendian. He said, I had 4 missions in Palestine as a pediatric cardiologist, never frightened inside the West Bank, neither inside Gaza. So he's been to both, and he was and he felt very, very safe. He was only frightened at the Israeli checkpoint and maybe at the airport, but it was never aggression. It's probably just extra security question. So thank you so much. Thank you, Kathy. Thank you, Khulud. Thank you, Brandon. Thank you, Dr. Hassan. Thank you for our amazing organizers, especially Noor, who's spearheading this. This is an excellent finale and a call to action. Hopefully things will come back with the rest of the series in January. And we will have a lot of work to do in Palestine. Thank you so much. Have a great rest of your day.
Bye. Love y'all. Bye.
Bye, Kathy.
Bye.
Kathy. Miss you, Kathy.
Thank you.
Miss you guys.
Love you all.
Miss you guys.
Bye. So good to see your faces.
Yes.